Guys, can we start?
Yes, ma'am.
Yes, ma'am.
Abhilash.
Yes, just a minute. I'm having a look at the link. Just couple of minutes more. Sorry for the delay.
Hi guys, welcome to our second case discussion, and we are sorry to keep you waiting for these 15 minutes. So today our case presentation is on syphilitic lesions, and we will be discussing the lesions which are seen usually seen in the STDs, and we have Dr. Rupa guiding us today. The presenters for today's case are Vijayesh, who's a second-year medical student from KIMS Karad, and we have Shweta, a third-year medical student from Government College, Chandigarh. So I will hand it over to Vijayesh and Shweta, who will be presenting the case now. Are you ready, guys? Can we have your cameras on, Shweta and Vijayesh?
Hi.
Hi, yeah, we can see you. Vijayesh?
Yes, ma'am.
Yeah, okay, you can go ahead now.
So here we have the patient data. The name of the patient is Mr. Ram Sharma. He's 29 years old, male, lives in Sakinaka and Andheri, Mumbai. He's a graduate engineer and single. The patient came with the following complaints. There was red colored rash over both his arm and sole for the past 1 week. There were rashes on the trunk for past 4 days. The rash is non-itchy, and the patient also complains of fever and pain in the joints.
Tell me if the rash was blanchable or not. How will you describe the rash?
The rash was non-blanchable.
Okay, fine. Continue.
History of presenting illness. The patient was apparently asymptomatic 7 days ago when he noticed red colored rash over his palm and sole. The rash is bilaterally present on both the palms and sole and is non-itchy. It is associated with mild fever, malaise, joint pain for the past 7 days. Patient also had a painless ulcer on his penis 3 weeks back, but it dissolved on its own, so the patient did not visit the hospital. There are no aggravating factors. The fever is relieved on taking antipyretics, and the rashes started in the palm visit and then spread to the trunk. Past medical history, the patient is a known case of allergic rhinitis. There is also a history of eczema in childhood when he was 14-year-old. However, the patient does not report of diabetes, tuberculosis, thyroid, asthma, AIDS, and COVID-19. There is no history of surgical interventions in the past. Coming to family history, there's no significant family history and no history of skin malignancy. Drug history, the patient takes tablet fexofenadine, 120 milligrams OD daily for hay fever. The patient also reports of history to allergy of penicillin. There are cases of anaphylaxis. And the patient was taking Dolo 650 mg for fever and joint pain for the past 1 week, twice daily. Sexual history, the patient is sexually active. He also reported of history of unprotected sexual activity with a female partner 9 weeks ago. Personal history, there's no history of smoking, alcohol consumption, or substance abuse. The patient takes a mixed diet. He reports of normal sleep and appetite and a normal bowel and bladder movement. Negative history, there is no history of sore throat and pharyngitis. There's no history of any mucosal involvement, no history of travel or exposure to any foreign substance. There's no history of any blood transfusion in the recent time, and there's no history of target lesions all over the body.
Why have you asked? Why have you mentioned about travel history?
Ma'am, because the patient has reported a fever plus rash to rule out dengue as a cause, we have taken the travel history.
So for dengue, you take only travel history.
Ma'am, as such, according to the weather and the conditions, the travel history to any place which is endemic to dengue, so to rule out the presence of it. Also, ma'am, we even asked about the incidence nature of the fever. The fever was related to rash also only.
Okay. Actually, dengue is endemic in India also. So it is not very, the travel history is not very significant. You can mention, but dengue is also present very large in a lot, very common in India also. So that is not the case. Secondly, why have you asked for sore throat and pharyngitis?
Ma'am, because we have an incidence of fever and a joint pain, to rule out rheumatic fever, we have taken the history of sore throat and pharyngitis.
Okay.
Ma'am, could we request you to turn on your camera?
Yeah.
Thank you, ma'am. Okay, now Vijayesh will be taking over for the examination part.
Yes. Coming over to general examination, the patient is conscious, well oriented to time, place, and person. The patient weighs 70 kilograms. His height is 168 centimeters. He is well built and well nourished. There is no pallor, no icterus, no edema, no cyanosis, and no clubbing. Generalized lymphadenopathy is seen in the patient. The vital signs of the patient are: the temperature is 38 degrees Celsius, pulse rate is 80 beats per minute, it is regular in nature, there is no radio delay, and there is no radiofemoral delay. The blood pressure of the patient is 130 millimeters of mercury systolic and 80 millimeters mercury diastolic, recorded on right arm brachial artery in sitting posture. The respiratory rate of the patient is 14 cycles per minute. On examining of cardiovascular system, both the heart sounds are heard. There is no incidence of murmurs to rule out aortic regurgitation or involvement of the aorta. In respiratory system, normal vesicular breath sounds are heard bilaterally on both sides. Per abdomen examination reveals soft, non-tender abdomen. CNS, there is no focal and no neurological deficit. Now coming to skin examination. Multiple small symmetrical and erythematous papules on both palms and soles are noted. The papules are 3 millimeters in diameter. Patches with mild superficial scale on palms and plantar aspect of feet.
Tell me some differential diagnosis of erythematous. And by the way, the papules which you have mentioned, 3 millimeter in diameter, papules are never 3 millimeter. Macules are 3 millimeter in diameter. And secondly, tell me the DDs for erythematous papules.
Ma'am, it could be systemic lupus erythematous.
Directly systemic lupus erythematosus. Tell me some common DDs.
Ma'am, drug rash.
Yeah, can be. And
it could be Tyriasis rosea.
okay, and
it could be also donovanosis.
No, don't jump to
psoriasis.
Yeah, psoriasis, but scaling is present. But yeah, okay, I'll consider that. Then
it could be rash of dengue.
Okay, dengue rash is not very papular, but they are mostly petechiae and everything is present in dengue. Normally, only when there is like severe thrombocytopenia, only there you can see a papular rash. Otherwise, dengue rash doesn't look very papular. Yeah, next.
It could be history of corticosteroids.
Okay. Corticosteroids never gives you papular rash. There it can be lichen planus. There can be eczema multiforme. Okay.
Yes,
Yeah.
ma'am.
Next. Describe the rash more if you can.
The rash was blanching in nature. It is
Okay.
non-itching.
How are the borders?
The borders are well defined, but but it is increasing in size.
Increasing in size. But was it round? Was it oval? Wow, or the bot, or how was it exactly?
It was oval in shape, but like spreading in nature.
Okay. Was there confluence?
There was no confluence as such, but it was spreading on a large scale.
Okay. Was the rash monomorphic or polymorphic? All these things you have to mention.
Yes.
Like how the entire body rash, was it looking the same, or the rash was looking different in different parts of the body?
On the palms, we had hyperkeratotic papules, which are significant of secondary syphilis. And while on the trunks and the feet and soles, we had the same rash.
Okay. Continue.
So the epitrochlear lymph nodes were enlarged. Some lesions are slightly pigmented with disformation in some places. Similar lesions were seen on the trunk. They were blanching in nature. Hyperkeratotic papules on both palms were noted. Alopecia was noted on scalp. It was patchy in nature. We also call it moth-eaten alopecia. Flat, broad, moist lesions were seen in the genital area, also known as condyloma lata. Normal mucous membranes and the nails were normal. There is no incidence of photophobia.
Now you don't just read the differential diagnosis, explain me all the differential diagnosis. The next slide, yeah. Why you have mentioned each and every differential diagnosis.
Yes, ma'am. In chancroid, we get on manipulation, it bleeds. While in chancre, it is painless. Chancroid is painful. Also, the borders are irregular. Pain is present, pain is noted on manipulation. Also, the diagram microscopy and VDRL tests are negative for chancroid.
No,
Also,
even
the
if you don't mention all this, just tell me. I have mentioned chancroid because even in chancroid, you see an ulcer. But does the difference is that it bleeds, and this ulcer you did not see. So you don't know how it was on manipulation. But because of the ulcer, you have mentioned chancroid.
Yes.
Because in chancroid also, patient gives a history of an ulcer.
Yes, ma'am.
Yeah. What
Next one
organism is chancroid?
Chancroid. No, ma'am, I don't know.
Haemophilus ducrei.
Yes, ma'am.
Next.
Next up, we have systemic lupus erythemata. In that also, we see rash all over the body, but it is erythematous in nature. But we differentiate it from syphilitic rash from the treponemal test, non-treponemal test. Also, we can go for the history for the patient. As the patient gives history of chancre, so we could go for the syphilis. Next, we have dengue. In dengue, we get the sign of hemorrhages in the patient. There is a characteristic fever. Leukopenia is noted. There is thrombocytopenia. Next, we have Theriasis rosea. In Theriasis rosea, the lesions are annular in nature. Also, there are silver colored over the silver color patching over the lesion.
No. In pityriasis rosea, there is no silver color patches. It is seen in psoriasis. In pityriasis rosea, it is red in color. That is why it is called rosea, because it is red.
Yes, ma'am.
And it is seen on trunk.
Next, we have drug rash or erythema multiforme. But the drug rash is itching in nature. It also does not persist for a long time. There is no history of any drug-like medication which can cause such rash.
Good.
Next, we have rheumatic fever. There is no history of travel or any history of streptococcal infections. Also, we noted the history of chancres, so therefore we rule out rheumatic fever from the patient. Psoriasis, there is no history of glucocorticoids. Also the Auspitz sign, which in which there is pinpoint bleeding, is negative in psoriasis.
In psoriasis, it is positive.
Psoriasis, it is positive.
Yeah. And there is presence of silvery scales.
Yes.
With pinpoint bleeding on scratching.
Yes, ma'am.
So there were no scales in this, or there were scales in your patient?
There were no scales in the patient.
But you had mentioned that there were scales. Mild scaling.
Ma'am, also in psoriasis, we have a history of streptococcal infection. But here we don't have...
No. Psoriasis, no streptococcal infection. Psoriasis is an autoimmune condition. Very, like, it is not a relevant history, streptococcal infection.
Yes, ma'am. Also, we could get subungual hemorrhages in psoriasis and subungual keratosis. And also we have dactylitis in psoriasis.
Ma'am, we cannot hear you.
No, I'm saying, okay, you go ahead.
Coming to the investigation, we go for routine examination, complete blood count to check the platelet count. Microscopy, we use the dark ground microscopy, direct fluorescent antibody technique, and polymerase chain reaction, which is a molecular method.
Why
Now,
do you know
serological test.
the normal methods of staining in syphilis? First, tell me which organism causes syphilis.
Ma'am, it is Treponema pallidum.
Okay. Which are the other organisms present in this group?
It could be
What are they? Treponema pallidum is a what?
Ma'am, it is
Belongs to which family? Spirochetes.
Spirochete bacteria.
Yes, spirochetes. Now tell me the other spirochetes if you know of any.
Ma'am, no idea.
No idea? Have you heard of borreliosis?
Yes, ma'am.
Leptospirosis?
Yes, ma'am.
They also belong to spirochete family. And why do they don't stain by the normal methods of staining?
Ma'am, they have motility and curved shape.
No, not because of the motility. Motility is one thing, but because of that does not affect the staining. And what is the motility? How is their motility?
Ma'am,
Corkscrew.
corkscrew, yes.
And why do they don't stain with the normal methods? Because they don't have a cell wall.
Yes, ma'am.
Okay, go ahead.
Coming to serological tests, they are the investigation of choice. Non-treponemal test, we have flocculation test, that is VDRL and RPR. In treponemal test, we have TPHA, RTCF, FTA, ABS, and TPI test.
You know the full forms?
Yes, ma'am. VDRL is Venereal Disease Research Laboratory. RPR is Rapid Protein Rearginine. TPHA is Treponemal pallidum hemagglutination assay. And FTA is fluorescent treponemal antibody agglutination, flocculation,
No
fluorescent
problem.
treponemal antibody. Sorry.
TPI.
Ma'am, treponemal pallidum.
Treponema pallidum. What? Immunofluorescence. Next, Buschke-Ollendorff sign. What is Buschke-Ollendorff sign?
Ma'am, with the blunt end of a pin, we press the rash, and deep tenderness is observed, which indicates a positive test.
Okay. On the nodules, if you press, or on the papules, if you press on the lesions, you get deep tenderness. Okay. Next.
Now coming to Samadhi, a 29-year-old male presents to the dermatology department with a 7-day history of malaise, fever, and joint pain. He also gives a 7-day history of rash on his palms and soles. He had eczema as a child, but otherwise there were no skin problems. He takes tablet fixofenadine for allergic rhinitis once daily. He took paracetamol for the fever. He had a history of unprotected sexual intercourse 9 weeks ago. On examination, epitrochlear lymph nodes are swollen. Rashes are seen bilaterally on palms and soles, measuring 3 millimeters in diameter. Similar rashes are seen on the trunk as well. The rashes are multiple, symmetrical, non-pruritic, blanchable, and erythematous. On investigation, the Buschke-Ollendorff sign is positive.
Now tell me the other lesions, other sites where you can get primary lesions of syphilis.
Ma'am, it could be
Apart
chancre.
from the chancre which you mentioned, he had a genital chancre. So
Yes,
where you can get chancre apart from a male penis? What is going on in this Pride month now? So
Yes,
syphilis is common in homosexual men, right?
Yes,
so homosexual men, where will they get a rash?
anogenital
Where
region.
will they get a skin? Where?
Anus.
Yeah, where else?
It could be oral mucocutaneous lesions on the tongue.
Yes. And in the throat, near the tonsils.
Yes, ma'am.
Okay. On the lips.
Yes, ma'am.
Next. Anywhere else you think you can get? Just any guess you think?
Ma'am, it could be axilla.
No. On the nipples.
Yes, ma'am.
Okay. Now, tell me what all is at least 5 to 10 manifestations, secondary manifestations of manifestations of secondary syphilis.
Then we have condyloma lata,
Okay.
skin eruptions.
Okay.
There is lymphadenitis.
What
The
is
classical of
exactly
which
condyloma lata?
it is seen in the urogenital regions like vagina or penis,
Moist area.
intertrigus area of the body, moist area.
Yeah.
Also,
How
we have
does it look like?
hyperkeratitis. We get epitrochlear lymphadenopathy, which is seen in secondary
I'm
syphilis.
telling you कि how does a condyloma data look like?
It looks like skin eruptions, like a red color with.
It is a papule which is pale red in color, and it may be confluent and present in the moist areas, and may be hypertrophic, raised from the margin, like raised from the normal skin tissue.
Yes, ma'am.
Yeah. And it is flat topped.
Yes, ma'am.
Next.
In secondary syphilis. Now coming to final diagnosis.
Then you were going to tell me 10 manifestations now of secondary syphilis.
Yes, ma'am.
There are many. At least tell me 5 to 10.
In secondary syphilis also there is hyperkeratotic papules on the palm.
You already mentioned in your case history, you almost mentioned 5, 6. Tell those only, it's okay. The girl before you, even she told, I think 5, 6.
Yes, ma'am. Hyperkeratotic papules on the palms. Also in secondary syphilis, we find mucocutaneous lesions and condylomalata. There is scattered rash over the trunk.
You mentioned alopecia. You told me he had
Alopecia, moth eaten. Yes.
Yeah. Yeah. What else?
Also,
in the history only you mentioned he had headache, he had myalgia, he had lymphadenopathy.
shorty lymphadenopathy.
And what else?
It could be neurological deficit as well in some cases.
Neurosyphilis it's called.
Yes.
But that is very late stage of syphilis. The final stage of syphilis is neurosyphilis.
Yes, ma'am.
And what else? You only gave me differential diagnosis, so many. Mention about those secondary mein.
It could be dengue.
Not dengue. I am asking about secondary manifestations. Dengue is a differential diagnosis. Why you give dengue as a differential diagnosis?
Because of the fever, rash, the joint pain.
Yeah, so mention rash now. It is a secondary manifestation. Now, what type of rash? 3, 4 types of rash are there in syphilis.
Yes, ma'am. It could be psoriaform, maculopapular,
yeah,
roseola, and malignant rash.
Papulopustular.
Yes, ma'am.
Then anything else?
Coppery red scale lesions or hyperkeratotic papules.
Okay.
There could be dull erythematic patches, mucosal patches seen on the mucosa commonly.
Okay, fine.
We have different ulcers like snail track ulcers.
Yeah.
Snail track ulcers.
Snail track ulcers. But snail track ulcers, ठीक है चलेगा snail track ulcers. Okay, fine.
Yes, ma'am. Ma'am, arthritis and periostitis, swelling of bone. Also, there could be hematogenous spray and dissemination to different organs.
Which organs?
It could be liver, testis,
and
brain.
Brain, okay. Eyes?
Eyes, yes, ma'am. Ocular manifestations.
Manifestations. And cardiovascular manifestations.
Yes, ma'am. Aortic stenosis or aortic regurgitation. It could be renal as well.
Okay. Almost all the systems are involved.
Yes, ma'am. In some cases, we even get lobar pneumonia. Consolidation of the upper right lobe.
Okay. Next.
So the final diagnosis. The patient is found to be diagnosed with secondary syphilis. The diagram microscopy shows corkscrew treponeme with characteristic rotatory motion. The VDRL test is positive. TPHA is also positive. The VDRL test is positive.
After how many days is the VDRL positive?
Ma'am, it could be 6 to 8 weeks after primary syphilis.
And TPHA?
TPHA remains positive for life.
Okay, have you heard about congenital syphilis?
Yes, ma'am. It could be vertical transmission during pregnancy if the mother is not vaccinated.
Okay, can you tell me what will be the characteristic features if you see a baby of congenital syphilis? Even 3-4 will do.
Ma'am, it could be Hutchinson's teeth, in which there is gap between the teeth.
Okay.
It could be keratitis, interstitial keratitis.
Yeah.
The
right.
corneal opacity is seen.
Mm-hmm.
Saddle shape, nose cleft.
Yes, saddle nose, yeah.
And also osteitis, periosteitis.
Mm-hmm. The child might have a small maxilla.
Yes, ma'am.
His jaw might be a bulldog shaped jaw.
Yes, ma'am.
We may have ruggeds. Then there may be presence of tibial thickening.
Yes, ma'am.
And Hutchinson's teeth, you said. Okay, fine. Anything else you know of? Interstitial keratitis also you said. In eyes, what he might have? What else? Corneal opacities.
Corneal opacity.
Fundus.
Yeah, there could be blurring of vision as well. Optic nerve will get affected due to neural involvement.
Very good, yeah.
It could be liver involvement as well.
Mm-hmm.
Splenomegaly too.
Hepatosplenomegaly, okay.
Lung involvement as we get in secondary syphilis as well. Lung fibrosis.
And all this is not very common. In perisynovitis or periosteitis, as you said, which
Yes,
most commonly?
It could be humerus or tibia.
No, knees or the elbows, Crouton's joints.
Yes, ma'am.
There may be presence of 8th nerve deafness.
Yes, ma'am. Ma'am, it could be ocular bleeding as well. Hemorrhages in the eye and in the brain as well.
Okay, in very later stage, it's not very common.
Yes, ma'am.
Next.
Now coming to the treatment, as the patient has history of penicillin allergy, we administer tablet doxycycline 100 milligrams twice daily for 14 days. Or we could prescribe tablet erythromycin steroid 2 grams daily for 14 days. We give 4 divided doses daily. Doxycycline is avoided in pregnancy. It is highly teratogenic in nature. We have to treat the female partner as well with post-exposure prophylaxis to avoid complications. Now advice. We have to advise the patient to have safe sexual intercourse with the use of condom, complete the drug course, avoid intercourse till the lesions heal. We have to advise we have to give the same advice to the partner as well. Encourage single partner relationship. We have to call the patient for follow-up after 3 months for HIV, hepatitis B, and VDRL test.
Okay.
Thank you, ma'am.
Welcome. You all are done?
Yes, ma'am. We will be starting with the MCQs now, and then we can have a doubt session for our participants.
Okay, fine.
Ma'am, one. Guys, you can start answering in the chat box. Okay. So this is the first question. Which of the following is the causative organism of syphilis?
Okay. Saponema pallidum. Next.
A second question. Syphilis is often called as.
No one's answering.
Okay, we have a couple of answers, C and D mix. So let's get to the answer.
So
The answer is C.
yeah,
The
C,
great
the-
imitator.
Okay, then next question. Which kind of lesions cannot be found in syphilis?
We have E as an answer.
E. E is the correct answer.
Next question. The characteristic mucosal lesions of secondary syphilis are.
We have D as an answer.
Very good. D is the answer.
Next question. Which form of syphilis does Lewy maligna represent?
We have A and B both as an answer. So let's get to the correct answer.
Even I don't know this. Lewy maligna. I haven't read about it.
Ma'am, the answer is secondary syphilis only.
Secondary syphilis. Okay.
Okay, so C is the answer.
C is the
Next
answer.
question, please.
All are true for secondary syphilis except.
We have D as an answer.
Correct.
Next question, true about the Zaris-Hexamer reaction is?
We have D as an answer again.
Yeah. It may be. Any worsening of the lesions in any stage is seen as Zaris-Hexamer.
Next question. Common to all rashes and secondary syphilis is?
Yeah, D is the answer.
We have D as an answer. Okay. Next question, please.
This stage is found to be the most infective of all.
We have B as an answer.
Yeah, B is the answer, secondary syphilis.
The syphilis which occurs due to blood transfusion is known as?
We have A as an answer.
Yes.
Syphilis. Yeah.
Yeah, also, I'll add one more question here. So in this condition, is the primary syphilis seen, or you directly see secondary syphilis?
Okay, so everyone is answering secondary syphilis.
Yes, correct.
Yes, correct.
Okay. The Fitzhugh-Curtis syndrome is found in all of the conditions except?
We have C as an answer.
No.
B is the answer, syphilis.
Yes. It can be seen in the chlamydial infection, gonorrhea, and genital tuberculosis as well, but it's never seen in syphilis. Okay. True about secondary syphilis is?
We have D as an answer.
Yes, that's correct.
Yes.
Okay. Thank you, everyone. These were all the MCQs which we could find on secondary syphilis. And we would like to
Tanisha,
thank Dr.
we have a doubt in the chat box.
Oh, okay. Ma'am, would you like to answer that?
Yeah.
Abhilash, can you read out the doubt?
Okay, yes. What is Fitzhugh-Curtis syndrome?
Fitzhugh-Curtis syndrome, it is a manifestation normally, which is actually there is presence of synechia and everything, which is present in your uterus. So, which is not seen in syphilis. Exact, like, it's a big question, but I know basically that the synechia and all present, and there is also basically, and all the lesions which are present. Hello, am I audible?
Yes, ma'am, you're audible.
You're
I'm
audible
audible,
now.
huh?
We couldn't
Yeah.
hear you a couple
It
of
can see.
minutes ago.
Hello.
Yes, ma'am. You're audible
Yeah,
now.
I'm audible.
Please go
Yeah.
ahead.
The uterus is involved, so and the neighboring structures are involved. There are synechia present, and it is seen mostly as an inflammatory reaction. And your neighboring structures which are present besides your uterus, they are involved. And it is seen in pelvic inflammatory diseases and diseases which are primarily involving your uterus. You can read about it in your textbook. Like, I cannot tell the whole thing, but this is what is generally seen. In syphilis, there are no lesions inside your uterus. So that is that.
Okay, ma'am. We have a second doubt. Ma'am, could you kindly explain the scaling lesions and definition of papules, plagues, and pustules?
Yeah. See, I'll start from macules. Macules are normally just pigmented. They can be hypopigmented or hyperpigmented, and they are usually less than 0.5 centimeter or less than 1 centimeter in diameter. They can be brown, they can be black, they can be white, hypopigmented, or completely apigmented. So these are macules. Now, papule is the bigger version of a macule, because a papule is more than 0.5 or more than 1 centimeter. It is bigger in size, and it is not raised above the skin. Like, it is present on the skin, it is not above the skin surface, so it does not have a height. It is also hypopigmented, like the same as a macule, just a bigger version of the macule is a papule. Then a plaque. A plaque is also a plaque is around like about 1 centimeter, less than 1 centimeter, but it is raised above the skin. Like it has a height of about 0.1 millimeter or 1 millimeter or anything, but it is raised above the surface of the skin. And it can again be hyperpigmented, hypopigmented, anything. And a bigger version of a plaque is called as a patch. So if it is more than 1 centimeter, you don't call it as a plaque, you called it as a patch. Then the next is a nodule. A nodule is also raised from the surface, but it has the borders are smooth, and it may be button like, or basically the borders are smooth. Like, it's not flat like a plaque or a patch. It is raised from the surface, and it does not have any fluid or anything inside it. It's just a mass which is raised from the surface. Then again, we have vesicles and we have bullae. Again, vesicles are less than 0.5 to 1 centimeter, and they are filled with water. Like, they are filled with some kind of discharge. And bulla is a bigger version of a vesicle, and it is more than 1 centimeter. And again, that is filled with some kind of discharge. So the discharge can be serous, it can be mucus discharge, mucopurulent discharge, or it can just be clear discharge. So this is it. These are the primary lesions that you see in dermat. Now I can give you examples. A macule, like I explained you, can be seen in rashes. Now, in particular, if you've seen rashes of pityriasis versicolor, then macules are present over the trunk, and they are hypopigmented or hyperpigmented, but mostly they are hypopigmented. Again, you can see macular rash in you can see in drug reaction, you can see it in measles, you can see it in rubella. All these have macular rash. Then again, papular lesions can also be seen, and papular, I told you, it is a bigger version of macules. It is also seen in drug rash or erythema multiforme. It can be seen in papular urticaria. Papular rash is seen, and it is again any color, hyperpigmented, hypopigmented. In acne, you can see papular rash. Then now we talk about plaques. and patches. Now, plaques can be seen in psoriasis. Plaques can be seen in lichen planus. Plaques can be seen in drug reaction. Then you can see it in normally plaques are seen in these conditions very commonly. Then in secondary infections, bacterial infections, in some bacterial infections also you can see plaques. Then vesicles can be seen most commonly in molluscum or herpes. Then bullae is the bigger version of vesicles. Bullae can be seen in bullous pemphigoid. Then bullae can again be seen in drug reaction. It can be seen in TEN, where there are bullae which are later ruptured. Am I audible?
Yes, ma'am, you are.
Then what is remaining? Patch. Patch can be seen in nevi. Patch can be seen in leprosy. Yeah, that is. You can see a patch in pityriasis rosea, where you can see a herald patch. Yeah, that's it.
Do we have any other doubts? Abhilash, can you check once?
PID and perihepatitis from Hiva Kazi.
What?
PID and perihepatitis.
PID and perihepatitis. PID is
Yes.
pelvic inflammatory disease. So many diseases come under pelvic inflammatory diseases. Like gonorrhea can come under pelvic inflammatory disease. You can have genital TB in PID, and you can have like many good list of diseases are there in PID. In perihepatitis, I just mentioned about that Vijayesh syndrome. In this, there is a manifestation that there is PID, there is presence of perihepatitis, and all these manifestations are a part of Vijayesh syndrome.
Okay, thank you, ma'am.
If
I
anybody
told you,
has,
right? That's your this thing is involved. Your uterus is involved, and the neighboring structures are involved. So the hepatite, your liver is involved, and all these things, and they have syncytia formation. There is presence of perihepatitis and all this. So that involves, there's a big list of things, and then that is called as Vijayesh syndrome altogether mixed up. Yeah, next.
That's all from the audience as doubts. Tanisha, go ahead.
yeah, okay, ma'am. We would like to end the session here, and thank you so much for joining us today and guiding us. And we will be sharing the presentation with everybody on your email IDs. And I would like to thank the audience also for joining us today. You have been a wonderful audience. So thank you, everyone. Thank you, ma'am.
Yeah, you're welcome. Thank you for calling me here.
It was our pleasure, ma'am.
Okay. Chalo then. Bye-bye.
Bye, ma'am.
Thank you.